3-year-old boy is frequently seen by his pediatrician for management of otitis media, nose bleeding, and eczematous dermatitis. One of his brothers had similar symptoms and died at 9 months of age. An uncle of the patient also passed away after an incident that led to fatal bleeding at 4 years of age. Serial quantitative immune globulin studies of the patient within the past 2 months have demonstrated markedly elevated IgA and IgE and decreased IgM levels. Which of the following neoplastic conditions would you expect to see in patients with a similar disease? As you can tell, this is a double jump question, and we have to choose among lymphoma, retinoblastoma, nephroblastoma, neuroblastoma, and osteosarcoma. From the history, you know that we are dealing with an X-linked condition associated with multiple infections, bleeding, and eczematous dermatitis, in addition to elevated IgA, IgE, and decreased IgM levels. This is a very good case scenario for Westcott-Aldrich syndrome. For now, I will give you the correct answer, and then we're gonna explain more details about this condition. Lymphomas are associated with Westcott-Aldrich. The famous triad of Westcott-Aldrich is thrombocytopenia, and that's why we had nose bleeding in this patient, infections, eczema, and lymphoma. Actually, this is a tetrad of Westcott-Aldrich, and I added in the lymphoma for you to make the story more complete. Let's look at Westcott-Aldrich. This is the next mixed B and T cell defect. It's a recessive condition, and the problem is in Westcott-Aldrich syndrome protein, the WAS protein, or sometimes they call it WASP protein. This is a cytoskeletal glycoprotein, and because of this defect, patients present with eczema, thrombocytopenia, and immune deficiencies. The WAS protein is mainly expressed in hematopoietic cells, and it activates actin polymerization. It is postulated that WAS protein is important for proper development of T cells and surface interactions with B cells. In the absence of this protein, T cells are unable to recognize the actin cytoskeleton. The dysregulation of secretory immunoglobulins is most likely related to this particular function of the WAS protein. These patients have progressive tendency for developing low B cells, low T cells, and low platelets. Classic symptoms of the patients include eczema, thrombocytopenic purpura, and recurrent infections. These patients are at risk for lymphomas and leukemias. As you recall, earlier I said that T cell defects in general are associated with a higher rate of cancers. In these particular patients, lymphomas and leukemias are the most common cancers. Treatment includes antibiotics and intravenous immunoglobulin. So here I'm showing the triad of Westcott-Aldrich, and I'm showing a whisker as your mnemonic here. Thrombocytopenia, recurrent infections, and eczema are the triad. And if you like acronyms, Westcott is your acronym. W for Westcott-Aldrich, also W for WASP protein, I for IgA and IgE that increases, and IgM that goes down, S for sex chromosome, C for cytoskeleton anomalies, O for otitis media, T for thrombocytopenia, and for low T cells. Let's look at immune deficiencies due to phagocytic defects. Let's start with a good case scenario. A 2-year-old boy is seen in the pediatrician's office for evaluation of a 5-day history of high-grade fever, diarrhea, and distended abdomen. Past history of the patient is significant for frequent respiratory infections, otitis media, and many episodes of high-grade fever since birth. His mother says that she is extremely worried because she had another son who presented with similar findings and passed away at 8 months of age. Skin examination shows irregular, hypopigmented areas on the face, abdomen, and back. Serology is significant for neutropenia. Light microscopy of the peripheral blood smear shows large, oval, reddish-colored inclusion bodies in the cytoplasm of the granulocytes. Which of the following additional findings would you also expect to see in this patient? Again, this is another double jump question. And as you can tell, this one also seems to be an excellent condition. However, we have hypopigmentation in this patient in addition to the otitis media that we saw with Wiskott-Aldrich. And another important finding is those inclusions within the granulocytes. The question asks you, would you expect macroencephaly, peripheral neuropathy, delayed separation of the umbilical cord, cold skin abscesses, or skin perforations? Of course, skin perforations reminds you of Wiskott-Aldrich that we just covered, so that is most likely not our correct answer. The correct answer in this case is peripheral neuropathy, and the patient has Shediac-Higashi syndrome. To give you a few high-yield facts for your exam, delayed separation of umbilical cord is seen with patients with leukocyte adhesion defects. Macroencephaly is seen in DeGeorge's, Downs, Pautas, and Edwards syndrome, in addition to Zika virus. Cold skin abscesses, as we covered earlier, is seen with hyper IgE syndrome, the so-called Jobs syndrome, and of course the skin perforations were associated with Wiskott-Aldrich syndrome. So let's look at Shediac-Higashi syndrome. And I have one good mnemonic here for you, the 5 P's of Shediac-Higashi, and you can refer to this mnemonic as you desire. And the picture below shows neutrophils with unique inclusions inside them. This is what you expect to see in Shediac-Higashi syndrome. Shediac-Higashi is an autosomal recessive defect due to defect in List gene or LYST gene that results in lysosomal storage and emptying dysfunction, defective microtubular functions that results from phagosome, lysosome fusion defects, and impairment of phagocytosis. So this condition is a phagocytic defect. Phagocytes, including natural killers, in patients with Shediac-Higashi syndrome are unable to deliver lysosomal contents to phagosomes to destroy the phagocytized bacteria. Characteristic neutrophilic findings in these patients are giant cytoplasmic granules, as you see in this diagram. Symptoms of the patients are recurrent pyrogenic infections, in particular with the Streptococcus and the Staphylococcus, partial albinism. This is from inadequacy of melanin distribution from melanosomes that they require proper microtubular functioning. And of course, as you can tell, the major problem with Chediak Higashi is polymerization of the microtubules. Peripheral neuropathy is an important finding. This is most likely due to microtubular defect that affects transmission of the neurotransmitters. Patients are at risk for progressive neurological problems. They have tremors, ataxia, sensory deficits, and progressive decline in intellectual functioning. Triad of Chediak Higashi: immunologic defects, neurologic defects, and albinism. A 5-year-old boy is seen for severe gingivitis and 2 non-healing knee and forearm wounds that he incurred while biking about 3 weeks prior to his visit to the office. History of the child is significant for delayed separation of the umbilical cord, frequent infections since birth, and extensive periodontal disease associated with his primary and permanent tooth eruptions. On examination, there is absence of pus at the wound site. Serology of the patient shows neutrophilia. Which of the following lab findings will confirm the clinical suspicion for the underlying cause of these findings? Low serum IgG, IgA, and IgM, low serum number of CD19 lymphocytes, lack of neutrophilic CD11, CD18 proteins, negative neutrophil oxidative burst assay, or negative platelet aggregation test. Well, let me give you the correct answer and then explain this condition for you. These patients lack neutrophilic CD11, CD18 proteins. Just to know, the patient has LAD deficiency or leukocyte adhesion disease. Recurrent bacterial infections, neutrophilia, lack of pus, delayed separation of the umbilicus, and severe gingivitis and periodontitis are cardinal findings of LAD. Flow cytometry shows lack of LFA1. The synonym for this protein is CD11, CD18, and beta integrin. These are adhesion factors on the leukocytes, including neutrophils, macrophages, and natural killer cells. Okay, look at the LAD deficiency, leukocyte adhesion deficiency. I'm showing in here a neutrophil, and normally the LFA is the leukocyte adhesion protein, is the one that identifies the bacteria, and I'm using the LFA for the mnemonic of olfactory, and this protein allows the neutrophils to identify infection in the tissues. As a caricature sort of mnemonic, this particular neutrophil is saying that I smell something fishy, and that something fishy is the presence of infection in the tissues. So this LFA will allow these neutrophils who are traveling in the bloodstream to attach to the endothelium and then migrate to the infection site. Again, LAD deficiency is due to neutrophilic integrin defect. This is the LFA CD11, CD18 defect. As a result, there is impaired neutrophilic migration and chemotaxis to the site of infection. These patients characteristically present with severe gingivitis and periodontitis. Characteristically, there is lack of pus and neutrophils in the wounds, and these patients have delayed wound healing. They have neutrophilia because the neutrophils will not migrate to the infection site and they stay in the blood. Uniquely, these patients have delayed separation of the umbilicus. Diagnosis is by flow cytometry showing lack of CD18. Treatment, use of antibiotics and bone marrow transplants. Again, this is the classic leukocyte adhesion deficiency is due to the LFA type 1 or LAD1. We have also an LAD3 defect, which is a less common subtype of the disease. This one is associated with lack of platelet aggregation and as a result, bleeding. This brings us to CGD. I have also covered this from a different angle in your biochemistry. In this diagram, I'm showing a macrophage or a neutrophil, and as you can see, because of that phenomenon that we call it the respiratory burst, because of that particular enzyme that is on the cell membrane of these macrophages, the NADPH oxidase, they drive the oxygen into their cytoplasm, convert it to superoxide, and then superoxide dismutase converts it to hydrogen peroxide, and hydrogen peroxide is going to be acted upon within the lysosomes of the macrophages by myeloperoxidase that joins chloride to hydrogen peroxide, and we're going to make hypochlorite. Hypochlorite, you recall this compound from laundry bleaches, and pour it at the bacteria and you bleach out the bacteria. I want you to know that both hypochlorite and hydrogen peroxide, they have bactericidal effects. Let's go through must-know facts of the CGD together. This is an X-linked condition for most part, and for most part it is due to NADPH oxidase deficiency, and as you can tell, this enzyme is encoded by chromosome X, and this deficiency impairs the microbicidal and phagocytic functions of neutrophils and macrophages. I want you to know that in chronic granulomatous disease, phagocytic function stays intact. However, the ability of the macrophages or neutrophils to kill the bacteria that they have phagocytized is impaired. In normal individuals, after phagocytosis, membrane neutrophilic NADPH oxidase converts molecular oxygen to superoxide free radicals within the phagosomes. This process is known as respiratory burst, and it is identifiable in neutrophils by nitro-blue tetrazolium dye reduction that turns blue, or chemoluminescence test in normal individuals. So normal individuals have respiratory burst, and you can identify it with nitro-blue tetrazolium or chemoluminescence tests. These patients, they fail to have respiratory burst. In some books on pathology, you hear that they say that the CGD is due to failure of the respiratory burst. This is what it means. CGD patients have negative respiratory burst, therefore. Two other less common defective lysosomal enzymes that may cause CGD are superoxide dismutase and myeloperoxidase, that normally they produce hydrogen peroxide, this is superoxide dismutase, and hypochlorite, this is myeloperoxidase. Both of these enzymes have a potent lytic effect on phagocytized bacteria. Symptoms of CGD include multiple chronic infections, especially with catalase positive bugs, such as Staphylococcus aureus, Aspergillus, Enterobacteriaceae, such as E. coli, Pseudomonas, Klebsiella, Shigella, and Proteus. Prominent clinical findings of the patients include pneumonia, osteomyelitis, diarrhea, liver and CNS abscesses, and granulomatous reactions in the affected tissues. Why? Because neutrophils and macrophages, they can phagocytize. the bugs, but they cannot destroy them. So the other immune cells of the body, they recognize presence of the antigens inside the cells of the innate system. Treatment includes interferon gamma preps, as disease is also associated with severe lack of interferon gamma. It is postulated that genes that are responsible for CGD may also be responsible for a number of inflammatory cytokines, especially interferon gamma and tumor necrosis factor alpha. A unique finding in patients with CGD is the predominance of catalase positive infections and minimal presence of catalase negative infections. You may refer to this diagram as I explain the pathogenesis of this difference for you. As I said earlier, in CGD, neutrophils are unable to make their own lysosomal hydrogen peroxide or hypochlorite. In the case of catalase negative bacteria, such as Streptococcus and Enterococcus, their metabolic activities within the phagosomes of the neutrophils produce some amount of H2O2, hydrogen peroxide, some amounts of hydrogen peroxide that is released into the vacuoles and acts as a substrate for myeloperoxidase, which results in formation of hypochlorite that destroys part of the bacteria, if not all of them, that are present in the lysosomes of that neutrophil or macrophage. Therefore, in CGD, catalase negative bugs express suicidal tendencies by producing their own metabolic H2O2. I want you to know that this phenomenon that I'm explaining here applies to the most common cause of CGD, which is NADPH, oxidase deficiency, and happens in the patients that they have functional genes for myeloperoxidase and superoxide dismutase. In the catalase negative microbes, bactericidal effects are preserved. The Streptococcus organisms, when ingested by neutrophils, can produce adequate H2O2 to provide a substrate for myeloperoxidase of the host neutrophils, as you see in this diagram. In contrast, catalase positive bugs are able to produce catalase, and catalase degrades the neutrophilic hydrogen peroxide in addition to the hydrogen peroxide that catalase positive bugs produce because of their own metabolism. Long-lasting survival of the catalase positive pathogens within the phagocytes is the reason that we see those granulomatous reactions in these patients. If you have been interested to know the short list of must-know catalase positive bugs, my mnemonic for you is spackle. Spackle is sort of a coating that we put on the walls before we paint on them, and in this mnemonic you spray essentially these spackle on the bugs, and you will allow the catalase to destroy their hydrogen peroxide. So spackle for Staphylococcus, Pseudomonas, Aspergillus, Candida, Klebsiella, Listeria, and the entire family of the Enterobacteriaceae, such as E. coli and Shigella. A 3-year-old male patient with an autosomal recessive inherited immune disorder is scheduled for bone marrow transplantation. The relevant history of the patient began within a week after he received BCG vaccine in anticipation for traveling to a high-risk TB country with his parents. Within a week after the vaccination, he presented with severe local reaction at the site of inoculation, fever, axillary lymphadenopathy that progressed to generalized lymphadenopathy, hepatosplenomegaly, and ascites. History is also significant for frequent viral infections, listeriosis, and salmonellosis. What is the most likely cause of these findings? Well, this is interferon gamma receptor 1 deficiency, or simply interferon gamma receptor deficiency. The widespread and disseminated microbacterial infection, the so-called BCG infection, is the classic finding in patients with interferon gamma receptor deficiency. In those countries that require neonatal BCG vaccination, and thus the vaccination has historically alerted the clinicians to the presence of interferon gamma receptor related immune deficiencies. What is the other immune deficiency besides interferon gamma receptor deficiency that causes BCG infection? L2 receptor deficiency. Both conditions present with frequent microbacterial infections. This was a good introduction to interferon gamma receptor deficiency. Now let's look at this deficiency, and of course, as you can tell, this is another phagocytic defect. Interferon gamma originally was known as macrophage activating factor, and it plays an important role in cell-mediated immunity and activation of the macrophages. It stimulates transcription of genes that play roles in apoptosis, defense against viruses, MHC protein expression, and type 1 T helper cell development. The receptor complex of interferon gamma is composed of two subunits, interferon gamma receptor 1 and 2, that are normally inactive. Upon binding of interferon gamma to these receptors, the two interferon receptors, they become associated. How do they get associated? They get associated via JAK1 and JAK2 proteins. This results in STAT1 phosphorylation or activation. Activation of the STAT1 protein now turns on several intranuclear transcription promoters and ultimately leads to interferon gamma effects. And of course, as you see in this diagram, as the STAT1 gets activated, then it causes ultimately formation of cytokines that are produced in activated macrophages. These cytokines may have pro-inflammatory function, they have anti-tumor and cytotoxic functions, they may upregulate the MHC molecules and antigen processing, they cause differentiation of the macrophages to epithelioid cells, they cause activation of the natural killer cells, and they cause activation of the T helper 1, T helper 2, and cytotoxic T8 lymphocytes and B cells. As you recall, interferon gamma is predominantly produced by the T cells, macrophages, and natural killer cells. Deficiency of this interferon leads to decreased tumor necrosis factor alpha and other pro-inflammatory cytokines that are required for MHC2 antigen complex development and antigen presentation to the T cells. Commonly associated diseases with interferon gamma receptor deficiency include disseminated microbacterial infections. This is by far the most important one. And as you recall, in that case scenario, you just gave the BCG vaccine, and that baby manifested with disseminated type of microbacterial infections. These patients also have increased susceptibility to viral infections, predisposition to infections with Listeria and Salmonella as well. Treatment includes aggressive and prolonged antibiotic treatment, use of cytokines such as interleukin-2, interleukin-12, and GM-CSF preps. GM-CSF stands for granulocyte, macrophage, colony, stimulating factor. An example is filgrastim. BCG vaccine is an attenuated strain of which of the following mycobacterial organisms? Mycobacterium tuberculosis, Mycobacterium avium, bovis, macroti, or Mycobacterium intracellulare. The correct answer among the given options is Mycobacterium bovis. There is an important unique anti-cancer role for BCG as a biologic modifier, and it's a good time for me to shortly make a reference to it. Intravesical administration of BCG is used for management of non-invasive bladder cancers. The vaccine acts as a biologic response modifier. That is, it has indirect anti-tumor effects. What does it do is that it induces bladder inflammation and stimulates the immune system to induce T-mediated immune response and anti-tumor reactions. Recall that T-mediated, CD8-mediated in particular, T-cell response is very important in controlling cancers. Note that BCG is used only in early stages of bladder cancer and in particular for carcinoma in situ of the bladder. BCG is also administered after chemotherapy and or cystectomy. We continue with phagocytic disorders. We have a few lower yield conditions. One is Costman's disease. AKA of this condition is severe chronic neutropenia. This is an autosomal recessive disorder characterized by severe chronic neutropenia and early onset of severe bacterial infections. Long-term implications of the condition include hematopoietic disorders such as myelodysplastic syndrome, acute myeloid leukemia, and osteoporosis. Treatment: use of antibiotics and granulocyte colony stimulating factors. With regard to B or T cell deficiencies, which one has a greater tendency to cause bacterial infections? B cells. B for bacterial. Patients have more tendencies for bacterial sepsis. T cell defects, on the other hand, has more tendencies to cause viral and fungal infections. What types of fungal infections are commonly associated with phagocytic or granulocytic dysfunctions? Candidiasis and aspergillosis. Infection with what organism is commonly associated with complement deficiencies? Neisseria.